Hi everybody, my name is Anil Karapurakar. I am an endovascular neurosurgeon. I now work at the British Candy Hospital, but I was a professor at the KM Hospital and St. GS Medical College. I thought I would show you some cases today. So the case we are discussing today is an 82-year-old gentleman who was symptomatic from ICA and basilar artery stenosis. So we'll be talking about the ICA and basilar artery stenting in this patient. He was 82 years old. He had 2 episodes of transient weakness of the right limbs with aphasia 1 year and 6 months ago. These were obviously left MCA territory strokes. And since 1 year, he had had progressive episodes of vertigo and ataxia on becoming erect. Since 6 months, he had progressive ataxia and he could not walk unaided. He could walk a few steps and then he would need help. He had occasional difficulty in swallowing and there was a change in his voice, it had become hoarse. He used a diabetic controller insulin. He was a hypertensive. He had had a bypass done and following the coronary artery bypass, he had symptoms. So again, he underwent stenting. And the CT scan had shown an old left parietal infarct. And the MRI as well was showing infarcts in the posterior circulation. And there were also, the new MR had shown fresh infarcts in the vertebrobasilar territory, in the thalamus, temporal lobes, and right occipital lobe. And the left vertebral artery was rudimentary, and there was a long stenosis of the vertebral artery and basilar artery and their junction, and focal severe stenosis of the left cavernous ICA, and mild disease at the carotid bifurcation in the neck. Unfortunately, I have not been able to preserve his MRI, but I will show you the angiogram. So, on the top left is the nominate injection, top right is the left vertebral artery, which you can see is rudimentary, and the bottom two show that it ends in the pica. There is no vertebral beyond the pica, so it's not contributing to the vertebrobasilar circulation at all. From the right side, the right ICA bifurcation was normal. The right ACA, MCA are good, but there is no support to the left side or to the posterior circulation. This is the left carotid injection, which shows a severe stenosis of the petrous ICA, the petrocavernous junction. And beyond the ICA again, the artery is not very smooth, the PCA being large. And this is the vertebral injection, which shows almost moth-eaten long lesion in the distal vertebral proximal basilar. The right ICA, as you can see, right AICA, as you can see, is severely stenosed. The disease starts just beyond the right pica, right PICA, and it's a long lesion. So the question was, should we do anything? This is a lateral view of this vertebrobasilar circulation. Should we do anything or should we just treat him medically? He was 82 years old. I thought that he was getting progressively symptomatic in the posterior circulation, and therefore we should treat the posterior circulation first. This patient had come from abroad and he wanted to get everything done and go back. He was already on Ecosprin 150 and Plavix 75 and Storvas after dinner. So after much discussion back and forth, it was decided that since there is no support to the posterior circulation either from the left, right or the left carotid, there was already a severe stenosis of the left carotid, we should do the vertebrobasilar stenting first. So after the angiogram again, we crossed the lesion with an echelon transient 14. And in those days, I liked a stabilizer wire. It's a cardiac wire. It gives very good support. So we crossed the stenosis using the echelon transient combination, removed the transient and got the 300 centimeter double length stabilizer wire across. The stabilizer, the distal 3 centimeters is very soft and floppy, and the rest of the wire gives very good support. So that's the one that we used. So we had parked the distal end of the wire in the right PCA, a long way into the right posterior cerebral artery, and then we did direct stenting. We had to deploy two telescoping stents of Zions, drug coated. Drug coated, I think, give much better results. The apposition is perfect. The alignment of the artery is good, and the long-term restenosis rates are very low. In fact, we've had very few patients come back symptomatic whenever we have used a drug-coated stent. When we have used a non-drug-coated stent, in fact, patients have come back. So we were very worried about the ICA here, because the ICA would have to be crossed to be able to come from normal to normal. The principle is always to have a stent going from normal to normal. So because this was a long lesion, one stent would not be enough. Also, a long stent would be difficult to navigate over the bends in the vertebral artery. And the upper row and the big middle row shows the result. So you can see what the tight stenosis was before and what it is like later. 1 week later, he was in the hospital for 48 hours, sent home after 72 hours. He was in the ICU for a day. Very good. He was 82 years old, remember. He was a diabetic, he was hypertensive, bypass. Speech was much better, and he could walk now without support. Since he was symptomatic for the left side also, and he was from abroad, he had already had 2 strokes on the left side, we decided that we would treat the left side. So a week later, we took him up. And this is his angiogram a week later, which shows that the vertebral artery and the basilar artery are virtually normal. The question was, there was a mild stenosis at the origin of the carotid ICA at the bifurcation. Would he need a stent there? So here, this is the left-sided angiogram. The tight stenosis can be seen. It's almost like a beak. And this is the disease at the bifurcation. So we had decided that we would go for the distal petrous ICA first. And we did it the same way. We crossed with a echelon and transient wire at that time. This was in 2007, I think we have done. So in 2007, we crossed with the transient wire and the echelon catheter, exchanged for a 300 centimeter stabilizer, and deployed a balloon mounted stent. This was also a Zions 4x15. We were worried at the turn whether the stent would take the bend, but it did take the bend, and as you can see here, the outcome was not bad. And on the way out, we decided to deploy a stent at the bifurcation, since we were worried that we have to maintain flow for the stent to remain open. So on the way out, we deployed a 7 mm by 40 mm Protege self-expanding carotid stent. And post-operative, it was uneventful. In fact, this I told you we have done in 2007. I saw him in follow-up about 3 years ago when he was almost 90, and he was completely independent. He was looking after himself. He had some cardiac problem, but he didn't have any neural problem. He had come all the way from Dubai for a follow-up because of the cardiac problem. Thank you for your attention. So, why I thought I'd show this is, one is it's an 82-year-old, symptomatic for both carotid and for posterior circulation. But luckily for us, the ICA remained open and the patient did very well. Thank you for your attention.